Let's go over the warm-up. First question, what are some of the characteristics of polymyositis that distinguish it from polymyalgia rheumatica? So polymyositis causes muscle weakness, as well as elevated CK, elevated aldolase, ANA, and anti-Jo1 antibodies. In polymyalgia rheumatica, there's joint pain, but there's no muscle pain or muscle weakness. And since there's no muscle inflammation, CK and aldolase will be normal. Then the last question says, which type of antipsychotic is often the first line of treatment for psychosis? Well, in general, it's going to be the atypical antipsychotics. And then which antipsychotic should be reserved for severe refractory psychosis because it can cause agranulocytosis? That's clozapine. All right, now let's get started with the lecture.
In this video, we're going to continue our discussion of diabetes by talking about diabetic ketoacidosis, DKA, which is an important complication of type 1 diabetes, and hyperosmolar hyperglycemic state, HHS, which is a complication of type 2 diabetes. And remember, diabetes is a 5-star topic, and diabetic emergencies are a 4-star topic themselves. So diabetic ketoacidosis is almost exclusively a complication of type 1 diabetes, and it sometimes can be the first presentation of diabetes, particularly in children, since they may not be able to verbalize symptoms sooner. So as a brief aside, I will mention there are some patients with type 2 diabetes who can develop insulin deficiency and get DKA. And there also is a syndrome called ketosis-prone type 2 diabetes, and these patients get DKA as well. I doubt this will be the case on your exam. However, if you see DKA there, think type 1. So let's focus on the highly tested stuff. I'll start with pathophysiology of DKA, then move to presentation, and then treatment. So we'll discuss similarities and differences with HHS throughout. All right, so first, pathophysiology. What exactly is diabetic ketoacidosis? Well, this is a condition caused by profound insulin deficiency, so the cells can't get any glucose. And of course, you remember that one of the jobs of insulin is to attach to a cell membrane receptor and open up a channel so glucose can move from the blood into the cells. So without insulin, there may be a lot of sugar in the blood, but the cells think they're starving because the sugar can't move inside. So the body goes to plan B for fuel, which is production of ketones. And we know that patients with type 1 diabetes can't make insulin, but they can make glucagon, and insulin and glucagon have opposing actions. So the job of glucagon is to help the body break down complex molecules into smaller pieces for fuel. And since the cells can't get the glucose, the body is stimulated to make glucagon, and it keeps making it and keeps making it until there's a lot of glucagon around, and the excess glucagon is pushing the blood glucose higher and higher, and that glucose load causes excessive polyuria, which leads to dehydration, and additionally, the glucagon is facilitating the breakdown of fatty acids into ketones, like acetoacetic acid and beta-hydroxybutyric acid. And those are decent sources of energy, but unfortunately they're also acids, and this leads to a profound acidosis. And our bodies are designed to work at a very narrow pH range, so when that acid builds up, patients get pretty sick pretty quickly. And the important thing here is the insulin deficiency and not the absolute glucose number. And some patients can have a dangerous acidosis with only moderately elevated glucose, at least by endocrinology standards, but it will almost always be higher than 250. So now let's contrast DKA with what we see in type 1 diabetes with the hyperosmolar hyperglycemic state that we see in type 2 diabetes. So the primary difference between DKA and HHS is that there is some insulin on board, and that prevents the excessive production of ketones. So remember that insulin inhibits lipolysis or beta oxidation of fatty acids, which is what generates the ketones. So if there's insulin present, there's no lipolysis, there's no beta oxidation, so there's no formation of ketones. So no ketones, no ketoacidosis. And unlike DKA, which can occur really at any glucose level, since the primary pathology is absence of insulin, in HHS you'll see glucose that gets much, much higher than in DKA. It will often be above 800, and it's not unusual to see glucose of 1,000 or 1,200 or even more. So it can get astronomically high. And this, of course, is where the hyperosmolar comes in. With all the glucose around, patients get an associated high serum osmolarity, often greater than 340. So again, it's called hyperosmolar hyperglycemic state. And you know there's no ketoacidosis, because if there were ketoacidosis, we would call this DKA, right? So let's move on to presentation and look at some of the more common precipitating factors for DKA. So this is in the study guide. Conditions that precipitate DKA fall into two groups. So first, there can be an absolute insulin deficiency, as in a new diagnosis of diabetes, or in an established patient who is not on enough insulin. And second, there can be conditions that put stress on the body, which increases production of catecholamines, glucagon, or glucocorticoids, all of which oppose the action of insulin, stimulating gluconeogenesis and ketone production for fuel. So as I mentioned, undiagnosed diabetes. Patients can present with diabetic ketoacidosis before they even know they have diabetes, and this is particularly common in the young. Then changes in medication, primarily missing the insulin. So a diabetic patient went out of town, forgot to bring his insulin, he could develop ketoacidosis pretty quickly. And patients with type 1 diabetes always have to have insulin, even if they're fasting, even if they're going for surgery, even if they can't keep any food down because of a stomach virus, even if they're tired of having diabetes and don't want to do it. This is critically important. And then there are things that can put this kind of stress on the body. So infections such as pneumonia, gastroenteritis, sometimes relatively mild things like strep throat, a UTI, or an upper respiratory infection. Then severe ischemic events like a stroke or a heart attack, and trauma. Again, this stresses the body and that increases catecholamines and glucagon and so on. And then dehydration can contribute, and alcohol or drug use could do it, particularly cocaine. Then precipitating factors for HHS are similar with respect to missing medications or physiologic stresses. So let's move on to the clinical features or characteristics of DKA. So there are symptoms preceding the acute illness, often are polyuria, polydipsia, and weight loss from the hyperglycemia. As a result of the polyuria and hyperglycemia, patients are very dehydrated. They also can get abdominal pain, nausea, and vomiting, but generally no diarrhea. They can have confusion or delirium. DKA causes the breath to have a sweet, fruity odor due to the ketones in the breath. And speaking of the breath, another sign of severe acidosis is called Kussmaul breathing, which is deep, labored breathing. It's often fairly rapid, but it can be slow. But the importance is that it's regular, deep, and labored. And it's the body's way of trying to compensate for the metabolic acidosis using the respiratory system to blow off carbon dioxide. So they're breathing very deeply, and now they're working hard to do it. Now, this acidosis is a metabolic acidosis, obviously, and it's an anion gap metabolic acidosis. So in the renal section of the course, you'll hear about acid-base disorders and the difference between metabolic and respiratory acidosis and the difference between gap and non-gap acidosis. But you probably already know the mnemonic MUD piles for the causes of high anion gap metabolic acidosis, and the D in MUD piles is for diabetic ketoacidosis. Also in labs, patients are going to have hyperglycemia, usually greater than 250, although there's no absolute number. And obviously you have to have serum acidosis in order to call this ketoacidosis. And with that, you'll also find ketones in the serum and ketones spilling into the urine. And these patients also have hyperkalemia, typically, or high potassium levels in the blood. So this is because with acidosis, there are excess hydrogen ions in the serum, obviously, and our bodies know this acidosis is dangerous, so the cells are going to try to get those hydrogen ions out of the blood and do something with them. So our cells have a hydrogen-potassium countertransporter, and that's going to pull hydrogen ions out of the blood, and at the same time, to maintain electrochemical neutrality, the cells are shoving potassium out into the blood. So the excess hydrogen is driving potassium out of the cells, and you get a transient hyperkalemia. Well, that's no good, right? Hyperkalemia can stop your heart and kill you too. So which organ can get rid of extra potassium? The kidneys. So the kidneys are going to start pulling potassium out of the blood and dumping it into the urine. And remember, these patients have polyuria because of the osmotic load from the hyperglycemia. So the patient is urinating a lot, losing a lot of the potassium. And the result of this is that the total body potassium will be very low. So on the labs, it may look like the patient has normal or high serum potassium, but the total body potassium level is low, and you just have to know that. So when you start treating DKA, and we'll talk about the treatments in just a moment, when you start treating, you want to watch potassium levels very closely. And as soon as that potassium level starts to normalize, you need to start giving potassium. Don't wait until the potassium is a little low, because these patients can get profoundly hypokalemic in a hurry once you start giving insulin to treat. Then one other thing to mention briefly is there are some dangerous complications associated with DKA. So as if DKA wasn't bad enough on its own, these complications can kill you too. So DKA can cause arrhythmias because of serum hyperkalemia and also from that total body potassium depletion, so both directions. And when potassium is low, magnesium can also be low, and that can lead to arrhythmias like VTAC, and specifically with the low magnesium, torsades. So with the hyperglycemia, particularly with DKA, patients can get invasive fungal infections like mucormycosis and rhizopus infection, which can invade the sinuses and cause a brain abscess. This obviously is pretty unusual, but when it happens, it is no joke. So as far as presenting symptoms, HHS can be similar to DKA, although the primary presenting symptom often is neurologic, mental confusion or delirium, maybe even coma. So patients can have severe dehydration and also nausea and vomiting, maybe some abdominal pain. So it's very similar to DKA in presentation. The distinguishing features are easiest to see on the blood chemistries and blood gas, primarily the presence or absence of ketosis, but also the hyperosmolarity and the extreme hyperglycemia. Okay, so let's move on here to treatment. How do we treat DKA? Well, first off, these patients are critically ill, so they're usually admitted to the ICU. And then we said these patients are very dehydrated, so you want to give them fluids, lots and lots of fluids, IV fluids because they're vomiting and often have impaired mental status, so you can't give it orally. Then you also need to give insulin, usually as a continuous IV insulin infusion. Casually, we call it an insulin drip. And the purpose of the insulin is not just to correct the hyperglycemia, which we've already said may not be that severe, but to inhibit lipolysis and put a stop to the production of ketones. So insulin is going to inhibit lipolysis and drive the cells to start using glucose for energy. So this, with the body's other compensatory mechanisms, will treat the acidosis, and we measure this by watching the anion gap. So when you're treating DKA, you don't want to simply follow the blood glucose levels and stop the insulin drip when the glucose normalizes. No, in some cases this isn't enough insulin to stop the production of ketones. So you need to keep giving IV insulin until the anion gap becomes normal or closes. And sometimes this means you have to give insulin and glucose together for a while. So once that anion gap is closed, then you can switch to injected insulin like you would normally use for outpatients. And the other really important thing, as I already said, is that you also need to replete potassium aggressively, and you may need to replete magnesium as well. So that's it for DKA. The treatment of HHS and type 2 diabetes is very similar. Fluids, fluids, fluids being most important, then insulin and potassium as well. But with HHS, you aren't really waiting for the anion gap to close because there's not an anion gap, right? No ketoacidosis, so no anion gap. So in HHS, you're giving insulin to get the serum glucose down and correct that hyperosmolarity. So now you're ready to pause the video and do the end of session quiz, and then we'll go through the answers. All right, let's go over the answers. First question, what are 3 important components of DKA management, and what about HHS management? IV insulin, IV fluids, electrolyte replacement, particularly potassium. Then the management of HHS is more or less the same, usually requiring much more fluid. And the big difference in management between these diseases is the endpoint. So for DKA, this is the anion gap, and for HHS, the serum osmolarity. Next question. What are the common precipitating factors for DKA? Well, you want to look for an infection, which could be viral or bacterial. You want to look for any dehydration. Maybe he's been sick and vomiting, and now he's dehydrated, or maybe he hasn't been taking his insulin, so his glucose is high, and now he's gotten into DKA. You want to look for a severe medical illness like an MI or trauma, although trauma is usually fairly obvious. And you want to think about alcohol or drug abuse. All right, that's it for this video. I'll see you later.
You've done it now, houseless.
I'm sorry, do I know you?
Are you kidding me? You're the jerk who wouldn't help me this morning, and now my patient is vomiting with severe abdominal pain.
Well, I'm sorry. As you can see, I am a very busy man, and I don't have time to help every insignificant intern that comes my way. What have you got for me?
2 Ensures and a dinner roll.
Fine then. Let's see what we got. Vomiting, pronounced thirst, decreased skin turgor, confusion, abdominal pain, and excessive urine production. Seriously? This is what you need help with? Didn't you check her blood sugar levels? Your patient is in diabetic ketoacidosis. She needs insulin to reduce blood sugar and suppress the production of ketones. She also needs copious IV fluids for her severe dehydration. Fetch. Don't you dare bleed on my porch!